today's session will be part of the activities that are planned to support the Estonian e-health governance model project, where Estonian stakeholders, together with the Minister of Social Affairs, our project partner Ernest Young, European Commission and international experts from EHTEL will be collaborating to redefine our new e-health governance model, together with its structure, the processes and KPIs in the model. And of course, to design a more informed model for Estonia, EHTEL is the European Health Telematics Association. So you know, they have prepared overviews of the e-health governance for 7 different nations. And today we will be hearing about the e-health governance in Belgium.
So good morning, everybody. So I will be trying to provide a summary of what the ICT governance looks like in Belgium. But first of all, you might know that Belgium is not an easy country. It's not a big size country. We have it's a limited territory with a bit more than 11.5 million inhabitants. But actually, we have 5 governments and 3 different languages, so French, Dutch, and German on our territory, which makes the overall political setting quite complex. It's also, from a health point of view, a Bismarckian system, so much more, well, I mean, quite different of what the presentation made by EHealth in Scotland. It's an insurance system. And when we look at how the health system is organized, actually, there is already, in dealing with health, per se, a lot of governance needed just to get the different pieces of the puzzle together at the federal level. And as you can see at the upper level there, we need political agreements for shared matters. And actually, sometimes social and healthcare are dealt with by the same people, but most of the time not. So, for example, we have 9 different ministers who need to get together to speak and to get agreement regularly on a number of issues. So the way that healthcare is organized is basically an insurance system, where you see here the national insurance system, which is the direct interlocutor of all the healthcare professionals. But we also have at the federal level here, the Ministry of Health, which has a direct role of programming, and we have the mutualities, so which are compulsory insurance, but which are organized freely. So we have not one, but quite a number. They used to be politically affiliated, but nowadays it's a mix. It's also, so we have some private insurance companies. So if you look at the health system, the very specificity of Belgium is that it has a lot, it gives an incredible amount of freedom to the patient, who can actually choose whoever he wants to see, and will be reimbursed 10 times if he goes and see 10 times a GP on the same day. There is no limit to that. So we used to have quite we don't have much delay. So there is a high accessibility to the services, and in terms of quality overall, there are some issues in some subsector, but overall the situation is quite good. The main question, of course, of the Belgian system today is, given the high level of freedom, is how to make it more efficient. And as we will see, this is one of the key priorities of the e-health roadmap. So if you look at how e-health is built in Belgium, it's the result of a bottom-up and top-down approach, actually, which resulted in a system where we have set up a framework, but I would say that was the result of a very vivid discussion. There was, first of all, a plan from the Ministry of Health to build a central infrastructure, not with the centralization of data, but just the fact that this central infrastructure would be built and controlled by the federal state has been seen as a no-go by the healthcare professionals, and especially the doctors, which completely refused. So we had to shift completely the strategy. Fortunately, before we had made any substantial investments in the infrastructure, as we see. So basically, the global infrastructure has been built with a sharing of responsibilities between the healthcare organizations who have organized themselves actually to become operational. The federal state, we created a structure to provide the 10 essential services that everybody actually needed in the system. We'll come back to that. And also to make available to all the stakeholders of value chain, of the e-health value chain, the needed, what we call validated authentic data sources. And they are meant for critical services such as identification and authentication, but that's for example, the National Drugs Repository or the National Healthcare Professionals credentials, for example, but there are quite a number of them. So there are databases which are used by all the systems and which in itself already provide a great deal of interoperability in the system also. Not only security, but also interoperability. And that's the responsibility of, depending on the kind of data source of the different public authorities. So the key point is there is no central data, no personal data stored centrally at all. They remain under the control of the healthcare provider, and the healthcare provider up to now can decide by themselves what to share or not to share. It's an evolving discussion, but in Belgium, the consensus has been to give time to time so that progressively the healthcare professional could be bought in the idea that that's not a danger, but that's a main plus also for them. That could be a win-win situation. So I think, shift to the next slide to explain you basically more in detail, but just the last here bullet point that you can see, most of the first services which were developed in Belgium were mainly public health and regulatory oriented. But there was one must, which came very quickly, is that it had to come with an administrative simplification for the healthcare users. So there has been quite quickly a kind of gatekeeper in order to avoid the multiplication of e-services, which would make the work of the health users more complex or with more burden. And we also made a big effort for the secondary use of data to make a full inventory of all the databases which had been created either by public authorities or by scientific organizations, so on, and progressively to go to only once policy. And that's in link with what I just said, administrative simplification, so trying to prevent the duplication of data. So if you look quickly in those slides here, that's the 10 key services which everybody agreed that had to be provided to all the services, e-health services, centrally by a national organization which was created in 2008 called the Belgian EHealth Platform. And as you can see here, they are necessary to connect with the value-added databases that you can see down there and can be provided by different organizations, mostly public, and to deliver the services which then can be developed either by public institutions, but also by healthcare institutions, as we will see. So quite quickly, we now have quite a high level of digitalization in the health system. We have an electronic prescription system, which is now in full pace, and also implemented in the hospital care, which is the, and we have reached also a high level of sharing of data, not always structured, but partially structured. We will see that in a second. How does it work, basically? So I said we have no central data, no central data. So we need to find a way to fetch those data when there is request. So we have standardized a number of web services which communicate between networks. So the way it happened is basically that uh, we had networks which developed at regional level, but completely under the control of healthcare providers who have set themselves up as a non-public, non-profit organization, but are today funded by public money, but they are completely under control. And the only thing which is central is basically what we call a reference directory, where the web services ask if there is any information available for a patient. The question is asked to all the networks, and then it is possible for any system to retrieve, but to see the information available in all those systems. For the GPs, as you can see here, we have also Vitalink, Intermet, and Presave, which are containers which allow the GP to stock online, to store online their information. And that's also in two regions, so the Brussels region and the Wallonia French-speaking region. Those containers are under the control of the healthcare organizations I mentioned. In Flanders, so in the north of the country, where the regional government has got a very much more active policy in terms of e-health. They are the driving force, but once again, the governance is assured by healthcare provider also. There are a number of conditions in Belgium which have been fully implemented in order to have access to the data, the patient consent, the proven therapeutic link with the patient. There is also differentiated access according to who you are. So if you're a nurse, if you're a doctor or a dentist, you don't have the same rights, of course. And I just mentioned that one. Just to make things complete here, you see the different networks down there. You have the EHealth platform, the authentic sources, and then that's another service. So for electronic prescription, that's also a non-public organization which is organizing the e-prescription service and the storing of data. And MyCareNet is basically all the insurers themselves who united to provide an orchestration of the services linked to insurability, and which are also using the key services. So that's the picture you can see of the global levels. The last few years, of course, there's been in Belgium, like in other countries, a focus on the citizen PHR, although it has been very difficult to reach an agreement. So you have for a patient different possibilities. You, of course, can access local portals, but you have a federal portal called My Health, Ma Santé, in French, which is a pointer to different portals managed by different entities. And once again, no centralization of data. With the COVID, we have now much more interest from the citizens for this portal, as it's the first time that some data were made available by some regional vaccination initiatives. But basically, it's an orchestration of the services provided by all the other actors of the system. Here, as you can see, the hub, Meta Hub, it's a fully deployed shared EHR and not HER, sorry for the typo, and where basically all information, so the lab results from private labs, the images report, the surgery report, well, any information from the patient is possibly shared, and we are going towards a more compulsory framework where it will be defined what needs absolutely to be shared, although it works quite well already. And then we have quite a number of other specific registration frameworks for a number of data, which I just mentioned here: vaccination, medication, schema, implants, and so on. How do we deal with interoperability? We have set up different of layers for that. So we got, first of all, at organization level, we had to come with an agreement on governance, on how we would govern and what would be the rules. That has been the first stop, and we succeeded to do that. So any organization who wants to share data needs to agree with this organization framework. And then we developed, as I mentioned, the set of web services in order to make possible the exchange of data between the different systems, which were again compulsory. And then we developed for certain information, like in Scotland, the patient summary under the custody of the GPs has been very much instrumental in developing the first structured data, also with semantic elements. I'll come back to that. And we have been extending now this for quite a number of content. I will not go into full details. That's not the purpose of the presentation. But there is now a concerted framework, and we'll see how we deal with it in a moment. And if you look now at the local level, we started from a highly fragmented e-health system, and it has evolved towards a much more consolidated one, where we have now only 6 softwares left being used by the GP. And we'll see that we have a compliance and financial model in order to ensure compliance with the e-health requirements, especially for data sharing. And that has been also partially the case now for the hospital system, which has also consolidated, although many things will still happen in the near future. So how does it work from a governance point of view at the regional national level? As I said, that's the same that for the health, the general health topics. That's the interministerial conference, basically, which approves the e-health plan, and where, of course, the e-health platform has its own governance itself, with a management committee and a consultation committee. The management committee is more a representation of the usual, I wouldn't say lobby, but I would say the usual syndicates part of the health system. While in the consultation committee, you have more the people who are the movers or the influencers, the people who actually do things, who want to propose, and they are set up. There are a number of working groups there, working on architecture, working on content and services at the eHealth platform. But of course, only for the service that needs to be developed there. And then you have, at the federal level, the different agencies which need to work. There is a program director which has a very important role, as he is the one who is supervising the overall federal e-health action plan. And finally, we have the regional governments who have also their own regional plan. They work with the regional hubs, but as I said, the regional hubs have also direct access to the federal level. So you will read that, but that's a summary of all the different institutions which play a key role. As you see, we have begun to link social care, but mainly in order to decrease the administrative burden for the healthcare professionals. So, for example, any request linked to handicap or advantages in terms of insurance, so it's now completely orchestrated. But now there's still much more to do that. Cienzano is now a very critical role for data reuse. They have been playing a critical role under COVID-19, of course, and they are now leading major new initiatives for data reuse. At the regional level, we, as I said, have different positioning in the north of the country and in Brussels and in Wallonia. we have a very dynamic Flemish agency, while in Wallonia, they are much more relying on the regional networks controlled by the healthcare professionals. Although it is now changing because with digitalization becoming a high priority for everybody, there is more money and thus more possibility for the regional authorities to develop new initiatives. I will go quicker because I see, but you will see that also if you look at the stakeholder innovation levels, they have been much more developing recently, and that's also a consequence of the increased importance and money available for the sector. If you look at also the people, the skills and the competencies, that's been a very important aspect that's been developed in parallel. So the EHealth roadmap came together with initiatives in each region to support healthcare professionals in understanding all the services which were developing and using them. And that has been organized at product level, but also at healthcare professional level through, for example, the users club. While we also have seen very much empowerment of the patient organizations, and they have been devoted budgets in order to develop and to help them to get strengthened and to provide new initiatives. How did we approach the planning, the strategizing in Belgium? Actually, although the basic infrastructure was set up, I would say in 2008-9, there was no, it was only voluntary and still very much a proof of concept till we had a roadmap. And that roadmap started from 2012 on with a very wide, large consultation of stakeholders to build this first roadmap. And then this has been updated in two iterations with more than the use of expert groups in 2015 and 2018. I mentioned already the program director. And from 2020 on, Belgium has decided that they will shift from a 3 years programming to an annual update in order for new initiatives to be implemented quicker and not to wait for another big review of the action plan. Sorry. I will go into there just to understand how we worked. Initially, we work with use cases. So we just try to put basically what do we need to have an orchestration of process and data to support key use cases. And we then reach a number of action points so that we had 20 of them, and they of course had to match a number of high and overarching objectives that you see on the left side. In 2015, it has been updated already to take into consideration mainly the need to take into account the patient. And then in 2019, the last version reshuffled the whole thing in clusters, in 6 different clusters, which has been translated in 44 approved operational projects. How does it work in terms of financing? Each public body is responsible for including the needed resources. So the plan is there that they need to make sure that the resource, and that works. That has worked up to now. The EHealth Platform has an annual dotation that's around 15 million euro, but they have also specific agreements with to support core services. So through and that's the specificity also in Belgium. We have one public organizations, but independent, which actually support all health ministries for the digitalization. So a lot of public bodies are actually relying on the SMALs and sign specific agreements with them to develop the ICT services they need. Finally, we also had a specific, from the start, we decided not to fund the providers, but to fund the users. through a policy which has more and more been driven towards meaningful use rather than just use of interoperable EHR. So, and that has been implemented through the National Insurance Institute or through the Public Health Ministry of Health and the hospital budget. And finally, we also included a new EHealth component with a validation pyramid of 3 levels, which includes also reimbursement. So we are one of the few countries in Europe which have decided to set this up and to have its own governance system. I will not go into detail here, you will read it, but there is no, just the key message here is that we have not a specific ICT and e-health budget for the budget for the hospital. They are free to use it, but the meaningful use policy actually obliges in a way the hospitals to evolve in the right direction. And that the same in the primary care system. So that's how do we deal with interoperability. We are discussing them in first of all the EHealth Platform Consultation Committee. They are for anything which is linked to the semantic resources. We have set up a public health terminology center which includes all the providers of semantic resources and which ensures the links with all the SDOs. While, as I said, the data exchange governance aspect I agree upon in reference to the circle of trust frameworks, which are also discussed in specific working groups. And that's an example of the way we are now discussing the inclusion of FHIR, for example, in the architecture working groups. For the here, I think I have no time to get into the details, but just how we develop new ES blocks. There is a procedure indeed to first validate the concept and then to create a testing environment for all the organization to test it and to validate it. Now, how can we monitor and maintain the blocks? There are a number of indicators which are monitored constantly and made available by the EHealth platform. And which leads, of course, to a versioning of the EHealth blocks necessary when we see need for improvement. And also the different projects and working groups can introduce change requests via the consultation committee of the EHealth platform. In terms of monitoring, also there is every 6 months the EHealth program director reports to the interministerial conference to provide full data on how the EHealth action plan is being delivered. There are of course KPIs for each project, but each project sets up its own monitoring process, and we have also the key central indicators collected by the EHealth platform. And for the implementation of the meaningful use policy, the system delivers themselves the KPI, as we only focusing on things that are objective visible, that can be objectivized in the system. In terms of stimulation of levels, I mentioned already the EHealth application. Cienzano has developed this only once policy in order to simplify and harmonize the registers. We have several innovation hubs which are active in the different regions of the country, which are now really benefiting from new resources. And there has been a consortium set up for artificial intelligence, which is cross-sector in 2019. And finally, many university Belgian hospitals are part of the European project. So just to remember what has been the journey as I mentioned, that has been very much a bottom up. I must say that, I mean, one of the big success is to have succeeded to have developed a fully deployed shared infrastructure, data infrastructure, with very limited public money, I would say, as most of the work has been done by the organizations themselves, who of course benefited from public money, but we from the start did not make massive investments. So you've seen that the budget of the EHealth platform is 15 million euro, and all the rest, of course, it's not the whole EHealth budget, it's much more than that. But the system is extremely generic, and interoperability in Belgium, because of the complexity of the system, was the only way forward. Actually, we had no other choice than just trying to have those systems communicating with each other and developing an extended governance framework, which would be as inclusive as possible. But the system get, of course, very complex. We have been conscious also. We took the time. We took the time to have the buy-in from the healthcare professionals so that they could test. We funded them in order to use what was that before what was developed, and we just wanted first trust to be established before addressing more sensitive and complex process like full access of data to the patient, for example. So I will get into detailed report on that, but just to show that has not been an easy journey. There's been a lot of stops, but finally the current situation is not the one that some people like. Some people would dream of a more centralized system, but that's not just possible in Belgium. There will be in the near future some centralization of data, mainly around medication, but again, fully under the control of the healthcare professionals and not managed directly by the state. So I already mentioned most of the successes. I think here in Belgium also we get some success with the public-private partnership, and as I said, the market consolidation. And the meaningful use policy has costed money. That's a lot of the EHealth budget, actually, to fund the users to use what is being developed, but has been successful, I think. We could do better. Clearly, the political alignment remains a challenge with the very complex political structure. We had different standards developed in parallel initially, and it took some time to have them realigned. The public bodies have been late in adopting the only once policy, and at some point, so that has been quite a paradox. Sometimes the most difficult to convince. A lot of competition between some initiatives. For example, there were no less than 5 proposals for a prescription, so that's been difficult to manage that. The lack of visibility for ICT in hospital budget is still somewhere an issue. So there is a need for global reform of the way we fund hospitals today. And the system also has been very efficient in a way, but today is also very much reliant on some individuals, and we need to open this up, and Belgium needs to make sure that the system is also sustainable without those individuals, I would say. And finally, the quality assessment and impact needs to be defined, and the overall strategy for data reuse is work in progress, but still partial.
Listen here again from the Medical Association Estonia. You mentioned that no personalized data is stored centrally. So is there some common coding, like we have this ID coding, or is the data completely pseudonymized, or maybe I've overlooked something there?
No, this actually, the data are pseudonymized if they are meant to be used for something else than continuity of care. But once again, not centrally. It's only linked to one specific objective and linked to a project itself, or to an organization itself, or an official public registry. Yes, there is one of the key services indeed which is provided centrally is to securely anonymize or pseudonymize data, so they can use that services freely. And if they use that services, the data are meant to be fully compliant with the GDPR. So that's a public service which can be used by any organization in the system, be it private, be it public. But no personal data is centralized at all. So today, just to make it clear, every hospital keeps its data. The GPs and primary care have their own system, but they are not online, of course, all the time, so they are not servers. So they fetch their data, they upload their data on dedicated containers, which are managed fully, governed fully only by the healthcare professionals of the different regions themselves, but supported with some public money. That's the way it works. So, and then we have more and more structured data, which is coming into that. And we have now almost reached an agreement in order for the information into to drugs, for example, the medication schema, to be handled not centrally, but the application itself will be much more demanding, and actually the people will mostly work as far as drugs management is concerned within that application, which will be a kind of plug-in, if you want, to the different EHR system working in Belgium. So no centralization of the drug data itself, but a plug-in application which in fact will make sure that, for example, one of the critical problem that we have with medications is medical reconciliation with the hospitals, for example, where you have it in the primary care, but most of the time when the hospitals are prescribing new drugs and so on, then it messes the whole thing up. So this new approach will guarantee a full reconciliation of data for medicines. And there's been an agreement in the governance framework in order to build this up. That would not have been possible 10 years ago. It is now considered as the thing to do. So there is some progress there.
Thanks. Thank you so much for all the presentations. It was very informative meeting, and thank you for all the participants for being interested in the e-health in the world, and for your continued support for this project. Thank you very much.